Welcome to this series of lectures in oral medicine. This lecture entitled Oral Infections. Oral infections. As you remember, disease of the oral mucosa can be divided into infective stomatitis, non-infective stomatitis, and malignant disease. Today our topic will be oral infections, and these can be fall into three main categories: those of bacterial origin, both aerobic and anaerobic; those of fungal origin, mainly Candida and other mucormycoses; viral herpes viruses, and HIV. Of the bacterial infections, you may get necrotizing ulcerative gingivitis, syphilis, TB, actinomyces, and others. Of the fungal infections, we'll mainly be concentrating on candidosis. Of the viral infections, we'll be talking about human herpes viruses 1 to 8, the mumps virus, and HIV. So if we first of all go on to bacterial, and especially necrotizing ulcerative gingivitis, formerly called ANUG. Necrotizing ulcerative gingivitis was also called Vincent's infection or trench mouth. Trench mouth due to the fact that it was fairly common in people in World War I who were fighting in the trenches, and mainly due to their poor oral hygiene practices. There's a distinct pattern of pathological changes that occur in the gingiva. There's no chronic form of the disease, so the previously called ANUG, the A has been dropped, so we now just call it necrotizing ulcerative gingivitis. Predisposing factors include depressed systemic immunity, stress related to corticosteroid hormone thought to alter the T4-T8 lymphocyte ratio. Other things that cause immunosuppression: smoking, local trauma, poor nutrition, poor oral hygiene, inadequate sleep, and recent other illnesses. So in this slide we have two clinical photographs from Neville Dan et al. Of clinical presentation of NUG. So they can occur at any age, middle to young, middle-aged. What you get is inflamed interdental papilla with a blunt, punched-out appearance, crater-like necrosis with a grey pseudomembrane, very bad oral odour and pain. There may be some lymphadenopathy, and a fever may also occur. Treatment involves removal of the bacterial challenge, and you get quick resolution following this, and this may be done by scaling and cleaning, oral hygiene instructions, chlorhexidine mouthwash, antibiotics such as metronidazole or penicillin, rest for the patient, investigate for possible immune suppression if treatment doesn't give quick resolution. Other oral infections from a bacterial point of view may occur from syphilis. Syphilis is caused by Treponema pallidum and is usually through sexual transmission or from mother to fetus. The virus is extremely vulnerable to drying and proceeds through three stages: primary, secondary, and tertiary. In primary, or chancre, develops at the site of inoculation, which is painless, clean-based ulcer, or similar to pyogenic granuloma, and it generally tends to heal within 3 to 8 weeks if untreated. The secondary or disseminated form occurs 4 to 6 weeks later after initial infection. Systemic symptoms may include lymphadenopathy, sore throat, headache, malaise, musculoskeletal pain. Oral lesions may appear such as red maculopapular areas, scarring, hyper or hypopigmentation. Mucus patches may occur in 30%, and if they fuse, they may appear like a snail track ulcer. Papillary appearance is called condyloma lata. Again, spontaneous resolution may occur. Tertiary or latent form may occur 1 to 30 years later, and it usually occurs as an indurated nodular granulomatous inflammation called gamma. Here we have some clinical photographs showing oral presentation, and here Hutchinson's incisor, and also Mulberry molar. An example of a mucus patch example of a gummer and some skin lesions. So again, this clinical photograph slide shows the presence of a primary lesion, secondary and tertiary lesions. Here's an example of condyloma latum and a gummer. With congenital syphilis, where the child has had the disease passed on to them through the mother, you may get, through developmental disturbance, Hutchinson's triad, which is Hutchinson's teeth, both incisors and Mulberry molars, ocular interstitial keratitis, and eighth nerve deafness. Usually diagnosis done through a smear showing spiral organism when examined by a dark peeled film. Serology may show antibodies to Treponema pallidum, and treatment is mainly through treatment with penicillin. Tuberculosis is a chronic infectious disease caused by Mycobacterium tuberculosis. Primary infections are usually asymptomatic and located at the apex of the lungs. Oral lesions are, although uncommon, and diagnosis usually occurs 2 to 4 weeks after exposure, and what you have is a cell-mediated hypersensitive reaction to the tubercular antigen. Treatment is with multi-agent medication. Actinomyces is a filamentous branching gram-positive anaerobic bacteria present in oral flora. Acute rapid progress to infection. Chronic slow-spreading lesion which causes suppurative discharge of yellowish fleck, often called sulfur granules. Diagnosis by culture showing colonies surrounded by polymorphs, as seen in this histopathological slide. Treatment is with penicillin. Impetigo is a superficial infection of the skin that is caused by either Streptococcus pyogenes or Staph aureus, commonly in children, and often occurs in areas of abrasions or cuts. Often the infection may be on the face with vesicles that rupture and become thick adherent crust. There's usually no systemic manifestation such as fever. Management may involve topical medication and or a systemic clindamycin. Here's a clinical photograph showing a child with impetigo lesions on the chin. Cat scratch disease is an infectious disorder beginning on the skin but rapidly spreads to lymph nodes. Most common cause of chronic regional lymphadenopathy in children is cat scratch disease, and is caused by Bartonella henselae or other henselae varieties, typically entering through a bite or a scratch. Usually it's self-limited, but persistent lesions may require excision. Again, here's an example of a lesion on the forehead of this child. Oral infections also may occur as a result of fungal organisms, and here we'll be mainly focusing on candidosis. Candidosis, the most common infection by Candida is Candida albicans, but other members of the family do cause infections from time to time. Clinical presentation may be, as seen in these clinical photographs, angular cheilitis, denture-associated candidosis, which shows an erythematous area on the anatomical surface of the denture-bearing area. Pseudomembranous candidosis, which is a white curd-like pseudomembrane which wipes off, leaving a red erythematous underlying surface, or a chronic hyperplastic candidosis. So if we look at candidosis, we can talk about acute candidosis and chronic candidosis. Acute forms are thrush, acute antibiotic stomatitis. Chronic forms are denture-induced chronic hyperplastic candidosis, chronic mucocutaneous candidosis, erythematous candidosis, and angular stomatitis. So in this example, we see a pseudomembranous candidosis in the soft palate, which can be wiped off with a wooden spatula, sterile wooden spatula, and smeared onto a glass slide, and then that can be stained with PAS to show this sort of pattern under the microscope, and you can see the fungal hyphae, which when present indicates infection. If it occurs in an adult male with no predisposing factors, you should query the present possibility of HIV infection. Other examples of pseudomembranous candidosis and denture-associated candidosis. Again, angular cheilitis, medium rhomboid glossitis, due to the fact that it occurs on the middle of the dorsum of the tongue and it has a rhomboid shape. So Candida albicans is the most common, but as mentioned before, other members of the family may cause infection. It's a notorious opportunistic pathogen, which means that when conditions are right, they take over. Carriage rate is 20% of the normal oral flora. It's a harmless commensal in the mouth of nearly 50% of the population, but as mentioned before, it becomes opportunistic due to a disturbance to the oral flora through decreased immunity. Increases to 40% in the presence of medical conditions, pregnancy, tobacco smoking, and denture wearing. Children peak carriage of 45% at 18 months, and usually occurs on the dorsum of the tongue. However, the mechanism by which they induce disease is not really known. It could be due to secreted enzymes, toxins, or antigenic response. So if we talk about factors that predispose to candidal infection, locally you may have mucosal trauma or presence of ill-fitting dentures, tobacco smoking. Age, the extremes are either the very young or the very old, again because the immunity is not optimal. Medications such as broad-spectrum antibiotics, which have disturbed the normal oral flora, steroids and immunosuppressive agents, which also affect the immunity. Xerostomia, or hyposalivation caused by medication, radiotherapy, or Sjogren's syndrome. Systemic disease such as HIV, iron deficiency, diabetes, leukemia, and some anemias. The three most common presentations are acute pseudomembranous, chronic atrophic, and angular cheilitis. Chronic mucocutaneous candidosis can also occur, and candidal leukoplakia, or also called chronic hypoplastic candidosis, is a little bit more clinically significant in that there's a slightly increased chance of dysplastic change of the mucosa, and especially if there's smoking associated with it. Treatment involves antifungal agents such as nystatin, amphotericin B, lozenges, and good oral hygiene, use of chlorhexidine mouthwashes, and if they've got dentures, maybe soaking them in either chlorhexidine or letting them dry out overnight will usually improve, but the dentures also need to be cleaned properly. In this slide we again have the different types of clinical presentation, their appearance and symptoms, common sites, and other associated factors. This is from Neville Dam et al. Other fungal infections may include histoplasmosis, infection by Histoplasma capsulatum, and most oral lesions occur with disseminated histoplasmosis. Usually treatment is with amphotericin B. If we now turn our attention to viral infections, again, as mentioned earlier, human herpes viruses 1 to 8 may occur, mumps virus, and HIV. If we look at HSV1 and 2, 2 being genital, the oral and the genital produce similar lesions and can occur in either region. Antibodies to one may produce cross-reaction against the other. HSV1 clinically exhibits the primary lesion, which is acute hepatogingival stomatitis or pharyngotonsillitis, usually occurring at a young age with fever and malaise and multiple oral ulceration. Secondary or recurrent ulcers may exhibit viral shedding, especially with ultraviolet light. HSV recurrence may trigger 15 to 16% of mucosal erythema multiforme, which is again another ulcerative condition that can occur, can be clinically quite significant. So diagnosis is through clinical history and serology, 2 samples, one at the initial stage where serology will be negative, and another one taken 4 weeks later, which will show positivity to antibodies. Treatment is symptomatic and also antiviral acyclovir suspension, rinsed and swallowed 5 times a day for 5 days, 15 milligrams a kilogram for a child and 200 milligrams per adult. Those with 6 or more yearly recurrences or immune compromised and or at risk of erythema multiforme, you may use prophylactic systemic acyclovir. Here's an indication of multiple oral ulcers in acute herpetic gingival stomatitis. Human herpes virus 3, varicella zoster, which is a primary infection, is a chickenpox lesions, which associated with malaise, pharyngitis, headache, and myalgia. Secondary lesions occur as herpes zoster and may occur even 10 years later. Usually spread through direct contact or droplet. Perioral and oral lesions may precede skin lesions and may be similar to HSV. Diagnosis again by history and clinical appearance. Serum samples at acute stage and 14 days later. Treatment or management is symptomatic and antiviral medications. Interesting to note that 10 to 20% may develop herpes zoster predisposed by immune suppression, stress and medication, or dental manipulation. HHV4, Epstein-Barr virus, also called the kissing disease, and because of infection through intimate contact, and it remains in the host for life. Prodromal fatigue, malaise and anorexia may occur in up to 2 weeks before body temperature of 104 degrees Celsius. Prominent lymphadenopathy, petechiae, pharyngeal petechiae, or hard and soft palate, necrotizing ulcerative gingivitis, chronic fatigue may be associated with this, although that's controversial. Hairy leukoplakia also associated with HPV. Diagnosis with increased white blood cell count, Paul Bernal test. Treatment usually resolves in 4 to 6 weeks, but you can use non-aspirin based antipyretics. Complications may be splenic rupture or Bell's palsy. Here's in this clinical photograph showing varicella zoster infection, which occurs on the dermatome of the maxillary and ophthalmic divisions of the trigeminal. Here, HHV4 Epstein-Barr virus, pharyngeal petechiae being shown here. HHV5 or cytomegalovirus is similar to HSV and can reside latently in salivary glands. 90% of infections are asymptomatic. Third may be present with pharyngitis and lymphadenopathy. Acute sialadenitis that affects all salivary glands may lead to xerostomia. Clinical features: biopsy may show LI cells, PAS staining to demonstrate cytoplasmic inclusions. Usually resolves spontaneously, but may be treated with ganciclovir in certain situations. HHV8 or Kaposi sarcoma, it's an unusual vascular neoplasm. 4 types occur: classic, endemic, or the African type, iatrogenic through immunosuppression, or AIDS-related. Treatment is through radiation therapy or chemotherapy with vinblastine. Some more examples of how some of these lesions may present in the mouth. Other viral infections include mumps virus or paramyxovirus causing a diffuse disease of the exocrine glands. 90% occur before 15 years, 30% of these are subclinical. So what you get is this enlarged salivary glands peaking in 2 to 3 days with pain on one side followed by the other. Can be unilateral in 25% of the cases. In males that get mumps after adulthood are at risk of becoming sterile. Most frequent report of enlargement of Wharton's and Stenson's salivary gland ducts opening. Generally, management involves supportive measures and non-aspirin analgesics. HIV or human herpes immunodeficiency virus and AIDS was first reported in 1981. Initially may be asymptomatic or acute response similar to infectious mononucleosis. Generalized lymphadenopathy, sore throat, fever, headache, myalgia, and peripheral neuropathies may occur. EC Clearinghouse's classification included 3 groups. Group 1, which is those lesions that are strongly associated with HIV infection, and these intraorally candidosis, hairy-leukoplakia, Kaposi sarcoma, and non-Hodgkin's lymphoma, as well as periodontal disease such as linear gingival erythema, necrotizing ulcerum, gingivitis, and periodontitis. Group 2 are those which are less commonly associated, as listed below, and Group 3 are those lesions that are seen in HIV infection. And here's an example of linear gingival erythema, hairy-leukoplakia, HIV-associated periodontitis, and necrotizing ulcerative gingivitis. Diagnosis with viral culture, HIV antibodies or antigens, enzyme immunoassay for antibodies to HIV. Treatment is ever changing and has progressed over time. Thank you very much.